So I'm happy to share what transcribed during the Pancreas sessions on Wednesday. We had a small group but really exciting discussions. We had the participation of 4 worldwide known surgeons and 1 nephrologist and 5 pathologists and friends. Just to put in perspective the pancreas issues in the whole context of the Banff meetings, the first discussion of pancreas was in 1995, and at that time we started working on a grading system for rejection, and mostly from samples of our center and with collaboration of Lorraine from across town in Hopkins, we did the first classification, and this was the 1997 when was really the beginning of the explosion of knowledge in kidney and interest in rejection classification, and the great paper that Kim mentioned in the historical review of Banff. So we tried and started with very little because pancreas biopsies are less frequently done, and it took 11 years until we managed to do the formal Banff schema for T-cell mediated rejection and subsequently the antibody-mediated rejection. Now, the pancreas is also different from with a mixture of features overlapping with the liver and the kidney, and also the fact that we have fewer amount of samples. So when this was done, we took a lot from the kidney, but it was a little bit of a leap of faith because we didn't have long follow-up and everything to be sure of what we were doing. And this is what it was really wonderful in the meeting that we had on Wednesday, because it became very evident now that we look at the whole aggregate of what has been done and how the classification has been disseminated, that the classification is widely accepted. This is a report from the first World Consensus Conference that happened just before COVID, but the manuscript is published, and you can see the large number of experts, and there are 9 points of recommendations on biopsies in this report, including, and it's too little, too small for you to read, but there are recommendations about how treatment should be according to the Banff classification of pancreas rejection. So this was presented by Dr. Ugo Bogi, who led this effort of the consensus conference. Similarly, John Odorico presented their experience, which is vast because they have such a large number of pancreas transplants and systematic use of biopsy. And he also presented several papers that are based, the clinical decision based on the classification, and this very interesting work where the formal recommendation of how patients should be treated, it is again strongly based on the Banff grades 1, 2, and 3, with very specific, and you can see here the survival with each of the grades, and you can see that it's almost linear, the correlation between these grades and the effect on the long-term effect on patients, and how the treatment decision for T-cell mediated rejection and antibody-mediated rejection, first with steroids, and then if it is grade 2 or more, thymoglobulin, and for antibody-mediated rejection, the standard, whatever is available currently. From Argentina, Dr. Uva presented also their experience with biopsies, and a very nice study of concurrent kidney and pancreas biopsies that they determined an algorithm to know which organ will give the highest yield if it is biopsied when there is a question of how to solve the problem, and there is maybe the pancreas has dysfunction or the kidney has dysfunction or both or none. So it's a very nice paper that is published in HHT. They also used, of course, the Banff grading system for another study that they did of biopsies at early re-laparotomy, 51 biopsies. So essentially whoever is doing biopsies is doing this, is using the Banff grading system, and we should continue improving on it and expand on what we know about pancreas rejection. From Brazil, Dr. Marcelo Perosa presented their experience with duodenal biopsies, and this is the duodenal cup of the graft, that when the anastomosis is done at a higher level in the small intestine close to the duodenum, it can be accessed endoscopically. And this is a question that we have discussed in previous Banff meetings. We never had a solid answer if it was useful or not, in part because we were waiting for him to be able to share this. They had the largest experience with clinical application, and they did use this for clinical decisions initially with these 134 duodenal graft biopsies, and then with a study of 23 simultaneous biopsies of the duodenum and the pancreas, and they had the conclusion is that, and this is similar to other studies, the conclusion is that in the with the graft has normal function, it appears that the duodenal cuff is not very sensitive or helpful, but if there is a graft dysfunction and the biopsy is done for cause, then there is some correlation, and it can be used to judge the status of the pancreas. So that was it's a slight advancement that we have not been able to reach any conclusion regarding that. The next part of the session was presented by Pedro Ventura, the nephrologist, enthusiastic, and it's nice to have young participants that have so many projects in mind. And he presented something that they have from Barcelona. He presented something they have already done on donor-derived cell-free DNA, the importance of allowing some time to pass, in this case 45 days after transplant, to reach a more normalized level of the circulating cell-free DNA. He talked about the correlations with the clinical markers, and he also presented data that in their cohort, even without graft dysfunction, patients that had DSA had high level of cell-free DNA. And then he took us in a tour of all the non-invasive methods for diagnosis of rejection, and some of these things are being done in their laboratory, and he presented a suggestion for future directions. Also related to non-histological studies, Surya session from Wilke Cornell presented the ongoing studies that she's doing on RNA profiling, and based on their experience on the kidney and urine, they are working on some biopsies that were taken for protocol biopsy. So they have a not huge but relatively good bank of material that is an RNA later, and that they are trying to do some discovery, because considering that the pancreas is potentially different, but also using the tools that they have. So these are initial findings of some differential expression of genes in rejection versus normal, and they are continuing working on that. And this it's also in the previous Banff, Candice presented the nanostring work. So there is on pancreas, and there was some indication of some correlation with T-cell-mediated rejection and antibody-mediated rejection. So there is slow but some advancement on understanding at a deeper level the process of rejection in the pancreas. Now the remaining of the presentations were all histological, and the first presentation was by Catherine Horsfield from London, and she revisited this situation where we have a graft that is lost fast after transplantation within the first 3 months. And they had a very nice study that looking at transplants that were lost by what is called technical failure, which is a general term applying mostly to the things that are not histologically defined. Their group demonstrated that 9 of the 23 explants actually had morphological features of rejection. They also saw some other non-rejection related pathology, but the really interesting, one of the new things that has not been said before is that in addition to the desire to have an accurate diagnosis when you have a graft that is lost because of thrombosis, also they saw that in the patients that lost the transplant due to antibody-mediated rejection, within 1 year the kidney was also lost in patients that had simultaneous pancreas kidney. So that is something that it's very interesting and justifies the need for to evaluate histologically these pancreas that are lost abruptly for potential technical reasons. The next presentation was Alexei Mikhailov from Wake Forest. Despite the fact that they do a large number of biopsies, it's the first time that they present in the meeting. So he presented studies of concordance or discordance between simultaneous kidney and pancreas biopsies, and you can see the degree of concordance. It's relatively low. It's not possible to absolutely rely on the status of the kidney to judge what's happening in the pancreas. And also similar to what has been seen in the kidney, he demonstrated that the patients that had DSA very often or more likely had several or at least some T-cell mediated rejection previously. Then the last 2 presentations were from John and me from our center. We looked at 97 biopsies that had CD3 and CD68 done, and this was with the purpose of seeing if there is a way to make the interpretation a little bit easier. There is a complaint, there is a working group from the American Society of Transplantation that is trying to analyze and revive a little bit the situation with pancreas transplantation, and they did a survey of all the centers, about 60 centers, and what is their impression about the pathologist's ability to give a diagnosis, and there is a big concern that the local pathologists cannot give a diagnosis with confidence, and this is diminishing the frequency of biopsies done. So we need to facilitate teaching material available to general or renal or GI pathologists that are looking at transplant biopsies. And we looked at this CD3 and CD68, following a little bit what is done in other organs like the heart, that is so helpful to look at the CD68 stain, for example. We looked at this issue of using an additional stain to help, and we think it does help, and I will show you what did we find. So the first part of the study was what John presented, and what it was done is a semi-quantitative evaluation in the septa and acini separately of CD3, CD68, and CD20. And this is absolutely semi-quantitative, and so we determined that baseline, based on a baseline of what are the baseline staining for these stains in 4 protocol biopsies, 4 pre-implantation pancreas biopsy, 4 normal areas in native pancreas transplants. And I'll show you I hope we don't have the picture here, but the baseline is a very slight sprinkling of CD3, is the most important stain. And then above that, when it is above the baseline, multifocal or diffuse, and we have some criteria to define, it is evident that the CD3 and the CD68, of course, increase with 1, 2, and 3 Banff grades of rejection. And if we look at the overall impact of CD3 and CD68 acinar inflammation, you can see how there is a direct correlation what happens with the graft. I mean, this is compared to what has been done in the kidney. This is very simplistic, but it's not, these things have not been done before. So CD68 similarly, the more CD68 is present. And so the first one is the acinar component, and this is the septal component. So when we looked at what happened with the impact on the diagnosis of the 97 biopsies, 46 biopsies, which is about half, there was no impact of doing the special stain. So essentially, this didn't change the diagnosis of rejection. But in about half of the biopsies, and these biopsies mostly were biopsies that were protocol biopsies or biopsies with no rejection. Now, when we look at the biopsies that had rejection, suspected rejection, or clear rejection, the special stains were really helpful to confirm, clarify difficult diagnosis. So these were about 80% were biopsies with rejection. And when of all these groups, 6 biopsies were upgraded when we looked at the CD3 stain, particularly the most helpful, from Banff 1 to 2 and from indeterminate to Banff 1. So here I show you an example of a biopsy that we will essentially call it, most likely I'm showing only one field, but probably we will call it Banff rejection 1. But when you look at the CD3 stain, it really makes you think that this is going to the next category, which is diffuse acinar inflammation. And this is really something that, depending how it's used, and interestingly, Surya, without knowing that what we were doing, she started talking with one of the surgeons, because one of the surgeons asked one question about the interpretation, and she started describing exactly the same thing instinctively. She is doing CD3 and CD68 stains, because you can really underestimate the degree of inflammation in the parenchyma. And this is it's a little bit different than the kidney where the tightly packed acini don't allow discrimination. So the immunostains can increase the sensitivity, contribute to some more accurate Banff grading, and also they are very good to determine treatment effect, and we are using it in our center when we look at the follow-up biopsy. So in this group of 97 biopsies, there were 8 patients that had one biopsy, diagnosed with rejection, and 3 weeks later had the follow-up biopsy after treatment. And of course, the macrophages are affected in an uneven way or not very significantly. But the T cells, of course, decrease very significantly if it is a successful treatment. So here you can see one example of before treatment and after treatment. And here you can see an example of patient that did not respond at all. So we have before the treatment and after treatment, the CD3, it's exactly the same. And we showed some other examples, John showed some other examples of intermediate situations. So, and for the sake of time, I'm not showing you all the Kaplan-Meier tables showing that the Banff grading as it is now really works well. In these 97 biopsies, we had perfect correlation of TCMR with the graft loss, fibrosis, arteritis, all the things that we use for the Banff grading are working really well. However, the addition of CD3 and CD68 stains, it can be helpful in ambiguous cases and can help in the differentiation of non-rejection processes. And this is what I presented. And this is what you see in this diagram that was initially presented by John, that we have here this group of cases that are not TCMR, and they may have septal infiltrates. They don't have the acinar infiltrate, particularly for the CD3 is the thing that is the most helpful. So the non-rejection pathology, we have 2 main categories besides the islet issues that we don't have time to present here. The 2 main issues that are non-rejection are suspected drainage impairment of the exocrine parenchyma, that is there just because it has to be, it doesn't have any particular value for the patient. But if we have drainage impairment in the exocrine part of the pancreas, there can be increase in enzymes, and the increase in enzymes is what triggers biopsy. So we need clinically, this increase in enzymes can look like rejection. So when we see the biopsy and we don't have rejection, we have to explain what's happening. And one of the explanations is this suspected drainage impairment. And we had other cases with bilateral proliferation, and we have some other stains that can be helpful for differentiation. So when we looked at the second non-rejection pathology is what Catherine Horsfield presented in her pancreatectomies, and we can see it in biopsies, is this peripancreatic reaction, peripancreatic infection, ischemic pancreatitis. These 2 processes are the bulk of the non-rejection related pathology, and that's the same what was in this group of 97 biopsies. When we compare the CD3 and CD68 with rejection, you can see that the septal and acinar CD68 stains don't discriminate. But if we look at the acinar CD3 and the septal CD3, but always the acinar is the most important because this is what really in the grading of rejection is extremely useful. You can see that really we can discriminate this non-rejection pathology from rejection pathology. So in this group we had 15% of non-rejection related pathology, and the absence of acinar CD3 was very helpful. So in addition to the other things that individuals are doing in the pancreas group, now with all these things that we have accumulated over the last years, we are preparing a manuscript that will have the collaboration with several of the clinicians that have have presented here and also in past Banff sessions, as well as some pathologies that have presented in past Banff sessions. Thank you very much.